this event. My name is Dr. Shankhdhar and I'm basically a diabenologist. And my job is to write prescriptions for diabetes as well as its complications like diabetic neuropathy and nephropathy. Okay. Now, diabetes is India's fastest growing disease. There are currently 72 million cases recorded, and they are expected to nearly double by 2025. India currently represents 49% of the world diabetes burden. Diabetes is a costly disease. Care for people with diagnosed diabetes accounts for one in four US dollars
there. It's not solving the purpose. And again, the necessity is mother of invention. And sometimes the patient came back to us. They just tied the device. They had no concept of a flooring, so they tied it on, the dorsum rather than the plantar, because he wanted to impress me that yes, the device, I'm using it, but it's not solving the purpose. So besides that, the social worker also reported that in some patients, maybe because of the higher body weight, it gets compressed, so we need to change it, and it doesn't cost much, so we can change it easily. So we thought of creating an irremovable modification to it. So sealing wax is available in the post office because our concept is that something should be available across the country. So we just seal the border using the sealing wax, and we stamp it with the stamp of our clinic so that we know whether it has been broken and it has been removed. And this is how it looks with the Samadhan irremovable version. Now, this is a study which was selected for oral presentation at American Diabetes Association way back in 2005, where we compared patient having dressing and common footwear as compared to Samadhan system added. So we healed more number of patients and in shorter time when we use the Samadhan system. It has been a number of people from different parts of the world have written to me that they are using this device. For example, besides India, a podiatrist in Australia, she's using it in East Timor. This is from Kenya. This is Samadhan system presented at a foot nurse training in California. As you can see in the picture, all those similar steps, including the picture of the dog, is being displayed there. And this is a huge honor for me that Professor Armstrong also presented the same slides at one of his lectures in America. So, and this is a podiatrist from Scotland. He visited Lucknow, and he used this device in Cambodia. And they are on Facebook and through chatting, people write to me that they are using it in Australia. For example, this is an Australian podiatrist using it in Tanzania, and they send me pictures that they have manufactured it, and we just share the journals and various comments. And this is when I presented it at Cape Town. It is currently present and published on the website of the International Working Group on the diabetic foot, feetforlife.com, and it was published in 2006 in this journal, Advances in Skin and Wound Care, where all the steps have been published. And this is the literature from Ipswich, which mentions that in the absence of resources and expertise, such measures, simple Samadhan system may be utilized. This is Current Diabetes Reports Journal, in which also we mentioned the simple approaches which we are using in the developing world. This is some media when I visited Croatia. So to summarize this part of the topic, Samadhan is a simple device. Depending on the lesion, the site of the lesion, we place the device and we clinically see it is solving the purpose or not. It is very affordable. It is designed for the masses. The things to make are easily available in the remotest corner of the country, of the developing world. It is designed for the developing world. It's relatively harmless because it's more made of foam, and it's accepted it has passed the test of evidence-based medicine in terms of it's published as well as it presented, and these are lectures from 2004 to 2006, and there have been many more after that. It can be used by the nurses. We don't need an expert podiatrist because we don't have any in the developing world. This is the team of Shankhdhars who invented it in the year 2000. As you can see, the year is mentioned. And this is a letter from King's in the year 2000 in which I shared the concept with the colleagues at King's. And finally, in 2009, I visited, 2003, I visited from 11th August to 23rd August, and we tested this using the MAT scan and the foot scan to see how it fares out there. So in this, we compared patient having dressing with the common footwear without a flooring, and when we add Samadhan system, let's see what the pressure studies tell us. So as you can see, when just dressing is there, the red zone is there, the metatarsal head area is having pressures, and when we place the device, the pressure is gone. So the pressure along the metatarsal heads has reduced, while the pressure at the heel remains the same. So there is not a shift of pressure, there is a relief from pressure. These are some more cases. As you can see, there's a lesion and we do the debridement, we do the dressing, and then we add the samadhan offloading. The steps are the same, how we are succeeding in bringing the patient from a lesion to healing. Now, the placement of the samadhan device is as per the location of the plantar lesion. If the lesion is in the forefoot, you place it just before that. If it is at the heel, you just place it after that. And then the challenging patient came who had the lesion in the midfoot. So we decided to place one before and one after because it's an economical device to use, and we succeeded in getting this patient, bringing this patient to healing. So you can imagine the cost of floating using other methods, while this method is hardly $1, $2, $3. So it's simple, affordable, effective offloading method. And that is the lady after healing. So this particular case was published in Journal of Diabetic Foot Complication. And finally, this particular method of offloading was granted patent in India. The application was in 2009, and from 9 to 2018, in fact, in February, number of documents were exchanged as they compared it with other offloading methods, and finally they agreed to grant a patent, and patent was granted. So the hidden strength in samadhan is its simplicity, and the biggest example of the fact that strength lies in simplicity, but is none other but father of nation India, Gandhi. During the freedom struggle in India, while Gandhi faced the armed foreign army, he was not equipped with guns and tanks. It was just the magic of his simplicity that won us freedom. Because the fact remains, it's only with simple things we can reach and serve the masses. Today, the samadhan system is probably only offloading method that is within the reach of the poorest patient, and the doctors working in the remotest corner of the globe can adopt it. The samadhan system may not be the best offloading method, but it could prove to be a boon to deprived diabetic foot patients. If a better offloading device can be arranged, well and good, but if not, then samadhan offers a reasonable solution to the problem. After offloading, we have put our attention on examination of the foot, because for one mistake made for not knowing, 10 are made for not looking. Now, foot examination is vital for diabetic foot amputation prevention, because 82% of diabetic foot amputations begin with a small ulcer. If managed well and early, 85% of diabetic foot amputations are preventable. So diabetic foot is a complication which is the most preventable complication as compared to nephropathy or neuropathy. So with this concept, we developed the samadhan foot stand. The word samadhan means solution. And as you notice, in various parts of the world, for example, in the United States, they have developed a 3-minute foot examination. The Canadians, they developed a 2-minute foot examination. And then they have developed a 60-second foot examination. My point is, what's the hurry? How can you examine the patient so quickly? And the answer is, the time is short, the number of doctors are short. You see doctors per 1,000. In India, there is 0.7 doctors per 1,000. So there's not much time to do the foot examination. So you have a doctor and you have so many patients. Now, I work in the diabetes center, and 100% of my patients are diabetes patients. So frankly, everyone needs a foot examination. The point is that because of time constraints, it's difficult to take a patient to the operative chair or have him lie down. That's the reality. No matter how much we advise, it's not being done. So we designed a samadhan foot stand. That's a basic design. So the target is when the diabetologist is seeing the patient, right there you have the foot stand nearby. Immediately the patient puts the foot on the stand. You get a good view of the sole. You get a good view of the web spaces. You can have a tuning fork and a monofilament. Quickly do a foot examination because you have very short time. We did the first modification. We added some padding there. And then we added another modification. We added a pocket for a handheld Doppler so that we can do a neurovascular examination and be satisfied that with what's going on. As you can see, the doctor, after inspection, is doing palpation and percussion and even the quick handheld Doppler vascular examination. And the cost of this stand is just $2. So the pharma companies, some of them have approached us. They want to gift it around to the physicians, and that's very nice because that's what we want. We want doctors to examine the feet quickly and treat the early lesions. And of course, this is pretty expensive equipment. So this is supported by the print media. They are also promoting foot examination as well as television media. Now let's talk about education, which is the backbone of diabetes management. Now, this is a very unfortunate incident. This is a type 1 diabetes patient in Canada, and his mother refused to accept insulin, and she tried to prove the doctors wrong, and finally the child couldn't survive, and then the parents were arrested for guilty of murder. And as you can see in this particular literature, 1 in 3 patients fail to take insulin as prescribed. So education plays a very important role, but if you just have a patient sit in front and if you try to educate them, most of them will sleep because they are known diabetic for many years. Now, I'm just 41 and I'm in practice for hardly 11 years, and I have patients who are known diabetic for 30 years. So when I try to educate them, they know more than me about diabetes because they have first-hand experience with diabetes. So having them sitting there and educating doesn't seem to work. But they are interested in movie, and we have a huge Bollywood industry, as you know, and we make twice as many movies as Hollywood. So we decided to let's use that and make some films on foot care. And practically speaking, if you see the number of mobile phones across the world, and if you have the countries, that's how the diabetes patients are there. The maximum mobile phones are in China, maximum diabetes patients are in China, India, USA, and Brazil. So if we are using the mobile phone for some good purpose, we have patients ready with the phone in the hand. So we use this method of education when we use the mobile phones, making films, and we call it Mobi films. And in fact, there was a contest organized by the Nokia phone company in which when Discovery Channel was involved, and when they noticed that I'm using the phone for scientific purpose, they made me an ambassador, and this is way back in 2006, when we did not have the technology which we have right now. And we made movies which talked about various aspects of examination as well as footwear. And we use, besides foot, we also make movies on diabetes, on diet, and we have them use them for education of the patients in a group or for single viewing if he wants to see a particular topic. As you can see, here is a patient watching a particular film. Then from doctors to doctors, foot examination, method of ABI, and debridement techniques, insulin administration techniques, and patients to doctors. We inspire the patient to bring in the photographs and the clips from home, how they are doing the dressing at home. Here's a patient showing me, you can see he's having a foot lesion, how he's dressing at home. I want to see the steps, and he can point out the mistakes, and picture speaks better than words. So you might tell me I'm eating this and this, but I want to see the snapshot of the dinner. What exactly is he having? And then I can point out how much carbohydrate and how much fat is there, or whatever. And then here is a girl, type 1 diabetes patient, who is telling me how she's taking insulin, and we can point out the mistakes, if at all she's doing any. And at that time, we used to have Bluetooth. That's the only way to transfer. So I can transfer the education film into her mobile, and she can see and replay and see the steps. Now, this method of education is also published by the International Diabetes Federation, mobile phone movie making the Samadhan system of diabetes education. As you can see, the same pictures were there. And way back in 2010, it was selected for oral lecture at Orlando in the American Diabetes Association conference. And it was published in 2010 in the Podiatry Today, emphasizing better self-care and patient adherence with cell phone videos. And there have been various lectures, as I said, and it was surprising for me that for 3 years, no lecture was selected from India, and this simple use of phone in education was used for a 30-minute oration at ADA, and besides that, various other places across the world since then. It has been appreciated by the media, and it became a front page news, and what's written here is, it is vital to prevent a foot attack in people with diabetes. That's the heading. So I was successful in getting it, the education through on the front page. It was for the first time of education for the diabetic foot was published as a front page news, and it's this particular thing is also published on the International Working Group on Diabetic Foot, television media, and we have videos on YouTube which are getting good view. Now, inspired by the success of photography of the foot, I picked up the DSLR to do some extracurricular activities also. So I did some wildlife photography. Well, that's also important. And then I did some portraits. That's actually my daughter. And then some street photography. When I just took this picture besides the flag, and then I noticed there was a contest in Ontario. And I sent this photograph, and it won the first prize, and I got the best scenic location subscription of Journal of American Podiatric Medicine Association. Anyway, coming back to education. So after the films, proceeding with the education of the patients, we launched a project developing a medical college for the diabetes patients' education, not the professionals, for the patients. And for the doctors, we have two conferences, Diabetes Update for Clinicians and Podiatry Update for Clinicians. Now, there was a patient, I was examining his feet, and he is a real estate person, and somehow he decided to give us a piece of land, and which helped us to proceed to start the mission. And we have this project which is 100% charitable. The land, the building, the staff education, everything is 100% free. So this was the land which was given. We constructed one room, and we started educating diabetes patients. And as we got support, we got some construction done there. This is 16,000 square feet of land. As you can see, everything is charity. And this is the basement being constructed. And then we had this lecture hall in the basement. And the government also supported us. They awarded us with a zero tax certificates, because of which no tax will be taken from this association and from the donors. Our goal is to make a building like this, although we have already started the work, and that is a diabetes education. So here, as you can see, I'm educating patients, and foot camps are being organized. You can see the biothesiometer and ABI being calculated. And this is a picture of a pamphlet way back in 2005, where we organized a camp for foot examination. There are various books in the local language which we have published. This is a book on foot care. This is the launch, and it was covered by the media. In DARCO, they purchased 500 copies for free distribution amongst doctors and patients. After that hall, now we have a number of rooms. Gradually, as the people are contributing, we are building, constructing the building is going, and we are also having a number of programs going on as they come. The World Diabetes Day celebration, participation by the, as you can see, young and old, and they are not coming here for treatment, they are coming here for education. So that's very important. So as you can see, the education talk is going on. And now this is interesting. This is a walk. This is a global diabetes walk, 425 steps, representing 425 million people with diabetes. So that is how World Diabetes Day global walk has to be done. As many million patients are there, that many steps we have to take. So this was a certificate which we got after this particular program. There's active participation. There's a pen and a paper. He has queries, and that's very nice. And that's some poem recital also going on besides that. And we have even more participation in the following year, diabetes quiz. And this is Jocelyn, who said, "The diabetic who knows the most lives the longest." That's very important. So we award the person who knows most. We give the award for the right answer. And the media is always there to support us, to publish our work. And we even celebrated Valentine's Day with the diabetes patient. As you can see, red roses being given to the diabetes patients. Now through the doctors, as I said, we have a diabetes update for clinicians. You can see the professionals being trained in diabetes as well as in podiatry. And we have the doctor from Scotland, he's speaking. And podiatry update for clinicians, as you can see. We have good participation because podiatry is something new for that part of the world. And here we have, as you can see, the doctor is explaining how to palpate the pulses, how to see the limited joint movement of the hallux, and this is the certificate distribution of the people who participate. So we have come a long way from a single room, and we are on our way to develop the building, but the project has already started and we are delivering the services. And this becomes an opportunity for people to volunteer, to donate, and we receive donations from California. All these equipments were sent to us, which all the nail clippers and the drills, so that we are able to do. And we have visitors, podiatrists from USA and New Zealand who come and they guide us how to proceed further. And she's a podiatrist from Cape Town and a vascular surgeon from Cape Town, Lynn. And you may offer me suggestions, and you can write to me at diabeticfootcare@gmail.com. The goal is to establish podiatry in India. Because the number of colleges in USA are 10 and the professionals are 13,000, DPM, Doctor of Podiatric Medicine in America, and in India we don't have any college and we don't have any podiatrist. And this article was published in 2008, living in a country where there are no podiatrists. And this effort was appreciated way back in 2005 in the newsletter called Helix at the Rosalind Franklin University in Chicago, and that's Dr. David Armstrong. Further inspiration from Wounds UK at Birmingham. This is the trophy which I received, and recently in March, our work was selected for the first prize in the best research from the developing countries at London. So I've been telling you some good things about the work which we are doing. There are some not so good things also going on, so I would like to share that also. And that's relating to the physicians as well as the surgeons. So let's talk of the surgeons first. Well, as the mushrooming of the corporate hospitals happened in the developing world in the past decade, a number of unnecessary surgeries and unnecessary amputations are being done. This is important for me because I'm trying to prevent amputation, and when this happens, a little bit of medical journalism has to be done to see what's going on. Now, this was published in a newspaper actually, which said that a senior orthopedic surgeon in a corporate hospital said that we have a quota to meet every month. Business they bring onto the hospital, they are paid on that basis. The worst is for the cases of stenting and knee change. This is as you can see, it is in the BBC that the Indian women push into hysterectomies. This is also in the BBC. Many of the operations are unnecessary. And this is from the USA. Unnecessary procedures. Doctors perform thousands of surgeries. The same thing is here. And the cost is around 150 billion, and 12,000 Americans die each year because of unnecessary surgery. So it's a significant thing. And this was also a gynecologist from New York said that 76 to 85% of the hysterectomies, if you take a second opinion, possibly they are not needed. And this is published in the BMJ, and a doctor from Calcutta. And he said that for 7 years I had to bear the burden doing unnecessary investigations and procedures, including angioplasty, and the pressure from the management of the hospital. And here's a twice award-winning doctor from the president of the India. And he gave an article in the newspaper, and he mentioned that the doctors have become greedy and they're doing unnecessary surgeries, and there was a knee-jerk reaction from the Surgeons Society of Jaipur, where they were pretty upset about it. The point is, this is not my research, or this is not my, this has been said a long time back in 1906, that society would pay a surgeon a large sum of money to remove a person's legs, but nothing to save it. This is a reality, and we must accept it. But we must remember that once we do an amputation, the other limb is also amputated within 2 years in 50% patients, and the mortality is as high as 68% in 5 years. So amputation must be avoided. Amputation must be avoided, and the focus should be on amputation prevention. And 85% of the amputations are preventable, as I mentioned earlier. Now let's talk about another thing about physicians. The price of insulin has increased. The average price of insulin has increased 3 times between 2002 and 2013, and there is a sale and there is a discount on everything except insulin. Now, as you noticed, this picture I had shown earlier, in this particular literature, as you can see, a significant portion of the patients do not reach the blood glucose targets, 88% of the physicians said. 9 in 10 patients desire less frequent doses, 67% reported that diabetes has controlled their life after initiation of insulin. Unnecessary insulin treatment is being given in some cases, and this is a publication in the British Medical Journal, 1981. And the data is from City Hospital at Nottingham. As you can see, I'll show you some cases. This is a patient, received insulin for 7 years. Diabetes appeared to deteriorate as the insulin dose was increased. And when insulin was withdrawn, the blood glucose fell in the range. Another case, insulin was withdrawn after 19 years of treatment. A dose of 52, her control improved and symptoms of intermittent hunger disappeared. While taking insulin, she had frequent symptoms of sweating, and as she was transferred from 60 units to an oral therapy with no change in control, life has changed 100% for the better. 3 of our patients had better control without insulin, and 4 had equally good control. All our patients were well 9 months after insulin was stopped. So it was not a short period. And then this is another interesting publication way back in 1983 in the British Medical Journal. A misplaced medal, 50 years of unnecessary insulin treatment, 50 years. Now this is a patient, 1927 insulin was started, insulin daily, 19 till 76 he was taking. Then he got an award from the Joslin Medical Center, Joslin Gold Medal in recognition of his successful treatment of insulin for 50 years. And after 76, in 79, when they measured the C-peptide, as you might be aware, it shows the amount of endogenous insulin production, how much you produce insulin from inside. And they found that he can produce insulin from inside. They withdraw the insulin, and he's easily controlled on carbohydrate-restricted diet. And then the doctor said, we have not dared to ask whether our patient should return the Joslin medal. You see? And this is not and then from that era to 2015, 330 patients, half of the participants, they were easily able to maintain control. And this is from Spain. They have proposed a number of reasons, including hypoglycemia, maybe some type of cancers, increase in body weight when you're taking insulin. So insulin should be withdrawn as far as possible under medical supervision. Now these are prescriptions, that's my handwriting, sorry for that, but I want to show you the real cases. Now this is a particular case, diabetes is not well controlled. The fasting is 180 and the PP is 265. This should be 130 and this should be 180. And this is on the 2nd of November. So she is taking 180 units every day. This is evident here, 40 units of Actrapid and 60 units of Lantus every day. This is expensive, this is painful, it is increasing the body weight. This is November, 180 units every day. In December, I reduced the 60 to 50, so it became 40 of Actrapid and 50 of Lantus. In January, I could bring it down to 90, 30, and 30, and in May, I stopped it. This is another patient. This particular patient, on the 6th of February, she is taking 62 units of insulin. As you can see, it is 16 of Humalog and 30 units of Lantus. Immediately, I reduced the dose to 40 units. As you can see, 10, and 10 only of Lantus. And on 13th February, I stopped it. As you can see, there is no insulin here, only oral tablets are there. Now, this particular patient is taking 34 units every day, 20 plus 14 of human mixed start 30/70. He achieved weight loss, he achieved fat percent reduction, and we stopped the insulin. As you can see, there are only oral therapy. So this really happens, and the approach should be there, and the magic happens when there is motivation and there is determination. The target should not, usually the target is glycemic control, but our target should be glycemic control as well as withdrawal of insulin. So the magic happens when you have the motivation and the determination of the patient and determination of the doctor. You have the activity, exercise, glycemic control through oral hypoglycemics. This is the backbone. Because once you are withdrawing the insulin, the diabetologist needs to use all the methods using the oral therapy to replace that insulin. Now we have 2 groups of medicines, as you know, secretagogues and insulin sensitizers. Secretagogue are glipizide, glibenclamide, glyclazide. These are the medicines which increase the amount of insulin in the body. And we have insulin sensitizer like metformin, pioglitazone. And then the new addition is SGLT2 inhibitors. These are the tablets which let the glucose out from the urine. So based on all those recipe of oral therapy, we are able to withdraw insulin. And this is only possible when you have C-peptide and you have endogenous insulin production. So this is not possible in type 1, where there is no insulin production. And obviously, calorie intake, we have to keep an eye on that. So we have an insulin withdrawal unit as well as type 2 diabetes reversal unit. Now consider one-man team approach. The point is that whenever you read about diabetic foot, you will read that every year there are guidelines that multidisciplinary team is required for the management of diabetic foot. You need all the experts to work together, and the patient is central. I've been seeing this for 10, 12 years, and this is very nice, this is very true. Excellent results are possible when the team works. The one and only goal of the multidisciplinary approach is to reduce the number of diabetic foot amputations globally. But the problem is, if you look into the literature, they are not actually reducing. This is a literature from 2005, one amputation every 30 seconds. Now we are having one amputation every 20 seconds. And this is a publication in which they say that 28% of the sites, when they did the survey, they did not have this team. Many hospitals in England do not have these teams as published in this literature. In the developing world, and the problem with this multidisciplinary teamwork is that it's pretty expensive. Now, $1.8 is the mark, international line, $1.8. If a person is earning less than that, he is considered living below the poverty line. And 20 to 25% of the Indian population is not earning that. So it's below the poverty line. It's not possible for them to have, it takes the fee is high, the appointments have to be taken, and they have to visit. So often only those who get care who have insurance and who have the facilities. And as I mentioned earlier, the cost of managing the diabetic foot has been increasing. So in the developing world, 80% of the people with diabetes are from low and middle income nations. As you can see, the red is the developing world and the yellow is the developed world. Besides all that, the problem is we don't have the experts. We just have the diabetologist and the surgeon. Now what? Another problem is that there is a difference in the approach. The training is different, the approach is different, attitude is different, reflexes and training is different. For example, a physician doesn't know how to do a below-knee amputation, so practically what happens is he tries to delay the amputation as far as possible. And the reflexes are different of a surgeon, you know that. So often a physician prefers non-surgical methods. And then what the ground reality is, as we heard in one of the lectures yesterday, there is a communication gap between the team, and the result is the healing is just not happening. So when we talk of the developing world and two people are there, then it's difficult to decide who will decide the treatment plan, and there is a blame game because we don't know who is actually doing what. So one of the options is, which may not be the best, but one of the options is multitasking. So it's a physician who will have to come forward, develop skills, and practice multitasking. And that's what we see in the other parts of the world. Other aspects of life. You see, there are very good cameras and calculators, but when you put everything together, then you get global success. So possibly the physician will have to bear the load and render both the diabetes care as well as the foot care, and besides other aspects. And this is what we call one-man team approach. Practically it becomes very economical because he just has to visit one doctor, one fees. There is better communication, the better doctor-patient relationship, and therefore better compliance. There is a sense of responsibility, and it is best suited for the developing world. It's just like having one driver, who is the physician, and one passenger, who is the patient. So it basically means that besides writing diabetes prescription, I have to do a little bit of foot care as far as possible. And therefore, in the morning and the evening, I do the dressings and the debridements. And in the afternoons, I write the diabetes prescriptions. And as you can see, there are some cases following the same pattern of metabolic control, debridement, dressing, and then offloading. And these are the similar types of, and we achieve healing. This is the same case, and for example, this patient having this superficial gangrene, we managed to save this foot. This patient having superficial gangrene, the line of demarcation is there. High chances are there that if he would have reached a surgeon, these toes might have been amputated. But we waited, we kept the foot dry, gave the antiplatelets, did the metabolic control, anti-lipids and everything, and we waited. And we found that we were successful in saving the toes. And I've shown you this picture earlier. So the magic happens when you get a good metabolic control, you do the aggressive debridement, ground clearance, that's offloading, infection control, and compliance. So practically, this becomes very economical for the patient. And basically, an MBBS doctor is a Bachelor of Medicine and a Bachelor of Surgery. So he should come forward and do some surgical procedures, because rare surgeries are needed rarely. Now, this concept was selected for poster presentation at Canada and for a lecture at Russia. And the way we work, and we are able to give affordable service to the poor patients. Our clinic was won this award, this medal, state-of-the-art diabetic foot clinic at Mumbai in 2017, last year. And I have been appointed a scientific head for this association in North America, where we will develop more methods for the developing countries. And I managed to get 3 fellowships, one in UK, this is Manchester, Professor Andrew Bolton, and 2 from United States, American Professional Wound Care Association and Academy of Physicians in Wound Healing. Now this we have read, treat the patient, not just lesion. This is very important. We have to keep an eye on patient's expectations and his frame of mind. As you can see, this has been published, consider the whole patient and not just the whole. Now, an average Indian patient should feel happy. He should be a happy person. India is a great country. India is the world's largest democracy. Economically, we are producing and exporting so many things. Academically, Indian doctors are everywhere in USA, UK. And on average, Indian reads 10 hours per week. That is the highest reading in the world. Financially, we have a Bombay Stock Exchange, which is the world's fastest stock exchange. Science, as I've told you, we have managed to reach the Mars orbit in first attempt. That is the first nation to do it. Entertainment, enough sources there. We are making twice the films than Hollywood. Peaceful. India has never invaded any country in history. We are the land of Gandhi. But the problem is, the ground reality is, that this man is not very happy. The average Indian is not very happy. And that comes in the way of my management of the diabetic foot. Because if my patient is depressed, it will come in the way of healing, because depression creates new problems. Now, when we look at the World Happiness Index, red are the regions where happy people are living, and yellow is a region where not so happy people are living. So that's a reality, we cannot ignore it. And India, the condition is worsened from 2013, and according to the World Happiness Index 2018, which measures 156 countries in terms of happiness, and they do that on the basis of various these factors, social support, life expectancy, and various these factors they take. They found that India is at 133rd position, a drop of 11 places from last year, and UK is at 19th. Why is India so unhappy? And that's a lot of unhappy people. Well, possibly because there is corruption, and the corruption is not a hidden, sometimes becomes so evident that it shocks me also. For example, when I saw this picture, I couldn't figure out what's going on. Possibly there is a fire and people are trying to evacuate, but the funny thing is that there is an examination going on, and these are the friends providing the answers. So there's a cheating in a school examination going on. So it just brought a smile on my face. And it was published in the Washington Post that India tried to stop cheating in the school, so 500,000 students just skipped examination. The problem is the children who are studying, they feel pretty upset about it because they don't know whether their hard work will take them where they're trying to be. Then this man, you might think he's trying to repair the electricity, but basically is stealing the electricity. So that's an electricity theft going on, and it is costing $16.2 billion every year for India. Imagine this money going for wound care, then you can do miracles. And they have a whole classification, like we have a wound classification, they have a classification of methods of stealing electricity. Anyway, so all these wires you see, this is all stealing going on, that's not supposed to be like that, but that's the reality. So besides corruption, people are not well. 21% of the world global burden of diseases in India. Poverty is there. There are a large number of married women who are not very happy, and that brings sadness into the family, working women. And diabetes reduces a woman's chance of employment by 50%. Housewives are depressed, their work is going unrecognized. Farmer, the poor farmer who produces the food for all, he's having a bad time. 41 farmers commit suicide every day. That's what they say. And I double-checked this figure. In 2010, 15,000 farmers committed suicide. There's unemployment. There is negative news in India. and there is cheerophobia. This is very interesting. Citizens in developing world are developing a fear of happiness. They are deliberately avoiding experiences that invoke happiness. Now, how do you help them? Suicide rates are higher in South Asians. It has been published. So the point is, why I'm telling this story is because it's coming in the way of our management. There are people who are poor, they are having illiteracy, they are sad and they are depressed and they are in negative frame of mind. How do you get compliance? And then they have a chronic disorder like diabetes, and large number of them, 25%, 30% will develop a foot lesion. At the time of diagnosis, they have neuropathy. So when he has that, and then he has a low resource part, he's living in low resource, he doesn't have insurance, there's poor government infrastructure, he becomes angry and he's frustrated. That's what's going on in his life. And that can turn into aggression and violence. And the soft target is the medical community. That's why I'm telling you this, because that's very important to see, and that's what's going on. And this is not an old picture, this is last month, 20th of May, and these are the nurses who should be busy working and making a difference. But they are busy, they have to protest, and they are not asking for an increase in the salary. They are protesting against the assault. And this is published in Lancet. Deterioration in the doctor-patient relationship in China and situation in India is worse. And this is a symbolic protest. You see the doctors working, wearing helmets and working, doing the ultrasonography. They are working, they are seeing the patients, but doing a symbolic protest. And this is from China, this is not just for India. Here a surgeon explained how he was stabbed by the patient. And this is an article where the doctor couple is just taking a pledge that they won't be having their child as doctor, because they say, when was the last time you saw a software techie being killed for not making an app properly? And this is a surgeon who was actually killed by this young man. He's a patient, and he was sentenced to death then. So this really happens. The medical resident hit by a patient. So one day everything will be well, that is our hope. Everything is fine today, that is our illusion. And we cannot escape reality. We need to be aware of the truth so that we can take the steps. And the Indian Medical Association has published in 2015 that over 75% of doctors have faced violence at work in India. And it's not just in India, as I'm telling you repeatedly, it's in different parts of the world. Reports are coming. While managing the diabetic foot in developing world, we need to keep an eye on patient's expectation and his frame of mind. It's very important, otherwise this will be the picture. Often the results of unrealistic expectations by poor families who have traveled and exhausted their saving on care expect medical miracles. So that's the problem. And reports are from everywhere, because we must remember that diabetic foot is more expensive to treat than top 5 major cancers. That's a report from Turkey, 10,000 assaults, and this is every day, the last year alone, 10,000 attacks in China. In just 2014, WHO received reports of 372 attacks in 32 countries, resulting in so many deaths and injuries. So we need to keep an eye on the expectation and the frame of mind. And this is a very interesting slide, because this again shows us the bare reality. And what it shows is time per patient. So in USA, a doctor is giving 21 minutes per patient. While in Pakistan, it is 1.8 minutes, and in India, it is 2 minutes, and in China, it's 2 minutes. So within 2 minutes, you have to receive the patient, you have to understand what's going on, you have to write the medicine and explain how it's to take, and he has to leave. So that's the reason. There is hardly any communication, and that's why you don't understand when he's angry and when he'll attack you. The doctor will see you. I can't promise he'll talk to you, but he'll see you. That's the problem. And the Delhi Medical Association published that 80% of the present consumer court cases filed against doctors is because of lack of communication. So that's the solution. Communication about cost, complication, and challenges. We need to spend time with the patient and explain what's going on. And doctors must make efforts to educate and inform the public at large about disease and what's going on, what could be expected. And there are measures like this patient health care questionnaire, where we can screen and understand the severity of depression in the patient. And the mnemonic is ABCDE. We need to give attention to the patient, develop a bonding so that the belief develops, communication, documentation, and education. Last point is adapt as per need. So whether which part of the developing world we are working or wherever we are working, we need to adapt as per need. Because it is not the strongest of the species that survives, nor the most intelligent that survives, it is the one that is most adaptable to change. So while facing the challenges of the developing world, the diabetic foot care professional needs to adapt as per need of the country, survive the challenges, and serve the community. Thank you.